Good evening, everybody. Welcome to This Week in Medicine. It's February 22nd, 2022. As I've been saying all day at work, it's 2-2-2-2-2. Very exciting. Remember, this is brought to you by Foxall Foundation, our education mission, which we're getting back to gradually. April, Dr. Yamamoto has been invited to the American College of Cardiology scientific rounds to give a talk, so we're excited about that. I'm going to tag along. Foxall Foundation brings you the Foxall Wellness Center, a great nutrition program with Carrie, and as things are opening up again after Omicron, we'll have some more fitness classes. We have Key Fitness right now, which is a great adult class that Mr. Ricky runs in the middle of the day, and we're working on more classes to help seniors and kids, everybody across the age spectrum at our Foxall Foundation Wellness Center. What came into the inbox? Well, actually, I had a question, do I need a stress test? Which thankfully we have a guest speaker this week, Dr. Yamamoto, our resident cardiologist, who will talk with us about women's health in particular as it relates to cardiology. Because again, this is Cardiology Awareness Month, Heart Health Month in February that we are wrapping up. Also, there's still some questions about Omicron and treatment. There was a new drug approved, but thankfully I haven't had anyone sick enough to need sotrovimab or Paxlovid, so I have not filled out any of these forms for the past couple of weeks. I could order those medications for patients, in particular at our local hospital, because I am on staff there, but thankfully haven't had to do that. A fourth shot does appear to be less effective, so I've had a lot of questions in the inbox about should I get a fourth shot. Doesn't look like a fourth shot is actually needed. Remember, a lot of things about this vaccine. Number one, it was based on a virus that we had in March of 2020. That virus has mutated a lot. It also looks like we have some very impressive T-cell immunity. There are B cells that function as antibodies, and there are T cells, two parts of the immune system that are actually activated by immunization. We can't measure your T cell response very easily. We do measure the B cell response, but that's not all there is to immunity, especially immunity against these viruses. So we don't think a fourth shot is needed. We'll talk about an article you can read from today's New York Times to help you understand that a bit better. There's also an ongoing trial of a Moderna Omicron booster, so hopefully we can be ready if Omicron hangs around or if it mutates and we need protection. I have a lot of patients telling me that their antigen test is not negative. I just got off the phone with somebody. She knows who she is, and she's frustrated because her antigen test is not turning negative and she's supposed to go back to work in 2 days. Just because we said you could go back days 5 to 10 with 2 negative antigen tests doesn't necessarily mean that is the norm. In fact, I really have not seen that. I don't have a patient yet who has been able to test negative days 5 to 10 and go back to work. In fact, I've had more patients who've still tested positive day 11 or 12 on a good quality antigen test. So for those patients, I say, I am sorry, you're somebody who did not clear this quickly for whatever reason. Consider yourself still sick and be wise, maybe stay at home. There are also a bunch of people in the past 3 weeks who are PCR test negative. Remember, the PCR test is the sensitive test. So if you were sick and you're antigen negative, could you be PCR positive? Yes, you could, because that test is so sensitive. It will pick up infection where the antigen test doesn't. So I've been highly suspicious for about 5 to 10 patients who report classic Omicron symptoms, but their antigen tests are negative and their PCR test is negative. I haven't seen this in the literature yet. I haven't seen it reported yet, but I really am suspicious if the virus has mutated enough that our old test, the PCR test, which is quite old, in terms of viral mutational lifespan, and the antigen tests are just not picking up infection anymore as reliably as they once did. So I guess my advice on that is if you do think you have symptoms suspicious for Omicron or COVID infection, or right now any viral infection, think about it possibly being COVID. Even if your tests are negative, you could still be contagious. So be wise. I know this is the time of mask mandates lifting, but if you think you're sick, it's probably wise to wear a mask. No one needs to know your business. You could be somebody with an immunosuppressed immune system from chemotherapy or from autoimmune disease. No one needs to know why you're wearing that mask. If you feel more comfortable wearing the mask, keep wearing it. I know I'm going to feel more comfortable in crowded situations. And I talked to someone today who has to fly back to Minneapolis for work. She's going to keep wearing her mask, especially on airplanes, because it really kept her from getting her usual bronchial infections. Finally, the last thing in the inbox is that mask mandates are lifting, but not in schools, not in hospitals, and not in healthcare settings, because again, we have immunocompromised and immunosuppressed people that we have to be concerned about. So this is the article I wanted to bring to your attention. It was in the New York Times. It's by Apurva Mandavili. This was a really good article. It's not too long, but there are a couple of things I want to highlight. Get a COVID booster. You probably won't need another for a long time. I agree with that. 3 doses of a COVID vaccine, or even just 2, are enough to protect most people from serious illness and death for a long time. And that's from studies that came out recently. So do we really need another shot? I don't think you need a 4th booster shot. Federal health officials have said they are not planning to recommend 4th doses anytime soon. And I do agree with this. I think we can all feel pretty safe and secure for those of us who have well-functioning immune systems and who got their booster shots, that our immune systems are up to the fight and we don't need to do a 4th shot of what is really an old vaccine. That being said, I now want to turn it over to our guest speaker, Dr. Yamamoto, who is celebrating Heart Awareness Month this February by giving us some educational points on cardiac health and wellness. Thank you for your attention. Remember your COVID antigen tests. February Heart Health and High.
I am Dr. Joshua Yamamoto. I am, as most of you know, an invasive preventive cardiologist, and I'm grateful for the opportunity to just speak for a moment about women's heart health, as February has been designated as Women's Heart Awareness Month. Sorry, I don't have a red dress, but you get the idea. A few quick things. Fun facts about heart health in women. It's the leading cause of death. Number 1 for women. Nearly 22% of women are going to die of heart disease, another 6% of strokes, and another 6% die of dementia. And if you have dementia of any sort, adequate circulation is a very important thing to have. So circulation is the major issue for women. We're very aware of breast cancer, and most women are very keen on understanding the risk of breast cancer and what to do to screen for it. But indeed, a woman with breast cancer has a 1 in 39 lifetime risk of dying of breast cancer, but still a 1 in 5% more likelihood of dying of heart disease. Meaning, heart disease is still the leading cause of death, no matter what, in women. 300,000 women are going to die a year from heart disease as compared to only 42,000 from breast cancer. To be clear, breast cancer is very important, but let us not forget that heart disease is the number 1 medical important cause for women to be aware of. So if heart disease is so important, what exactly is it? Today we posted a video of a lecture that we give on the nature of heart disease and our modern approach to that. There's a separate link. I encourage you to watch it. There are 3 things that happen to all of us as we age, including atherosclerosis or arterial disease, hypertensive disease or stiffer arteries overworking the heart, and conduction disease or the ability to have irregular heartbeats. All 3 of these things are just as, if not more important in women than men, yet we need to approach them differently in women than men. And all of them are a function of natural aging, so we always have to be aware of it. And today I want to touch mostly just on the arterial disease. So women do start life differently. Women are more likely to have inflammatory issues than men are. Women have greater vascular compliance than men do. Their arteries are stretchier. A pregnant woman has a 40% increase in blood volume and has to be able to accommodate that. Women go through their entire menstrual years with significant expansions and contractions of blood flow. Women have relatively smaller hearts than men do for body size, which makes an issue in terms of their ability to augment cardiac output, especially later in life. And one of the most important things is women clot with greater efficiency than men do, which makes a lot of sense because women have to deal routinely with bleeding that men don't. And not only do women start differently, they age differently. Atherosclerosis, or plaque buildup, was first demonstrated and really understood as an inflammatory issue in women, not a dietary one. No matter how many roots and berries we eat, we're not going to stop the process of aging and vascular inflammation, which is what gives us plaque. Again, please watch our longer video on the nature of heart disease. Women do have stretchier arteries and lower blood pressure in youth, which makes them more prone to fainting and lightheadedness, and they seem to have higher blood pressure when they get older, but this is a very understood biologic process of loss of vascular stiffening, or loss of compliance in a stiffening blood vessel. Remember, blood pressure is a number, not a disease, and you have to understand it in context. And we keep applying male context to women's numbers, and you can't do that. They're different. Women are more likely to only have exertional symptoms. Again, a smaller heart means when you get up and do more, especially when you're older, you may not be able to meet your needs, and women will get fatigue and breathlessness as their principal symptoms, not the things that we heard about in men clutching their chest for chest pain and all of that. Pain is rarely a symptom of cardiac issues in women. And perhaps most importantly, too, women are more likely to have strokes, meaning blood clots to the brain, not heart attacks like men do. So a couple of quick notes on the inflammatory process, why we develop plaque. There was a landmark study a couple of years ago called the Jupiter trial, where we looked at a lot of women for the first time, over 6,000 women. And you know what? They had normal cholesterol, not a dietary issue whatsoever, but they had blood tests that marked them, the CRP, as having more aggressive healing. Yes, inflammation is healing. It's a good and natural thing. Yet with 100,000 heartbeats a day, that relentless pounding on our arteries gives us all vascular injury and repair. So we grow plaque normally as we go through time. And women in particular are susceptible to the inflammatory component that makes us grow plaque. And so what did they do? They gave these women a statin. Not because they were treating cholesterol. This isn't the 1900s where all we do is name and shame every disease and say, this is what you have and it's your fault. No, as you age naturally, a woman is going to have inflammation which leads to plaque buildup. And they can stop that. We can stop that with a statin. And they gave these women who were perfectly healthy seemingly, who had normal cholesterol but an elevated inflammatory marker. And you know what? They had to stop the study early because it was so effective. That there was a 44% reduction in heart attacks and strokes, mostly strokes. And again, all this old data was on young men and their heart attacks, but women are going to have more aggressive inflammation, more aggressive clotting, and are going to have strokes as one of their major risks. So atherosclerosis is plaque in the arteries. In the 1900s, late 1900s, this was the most common form of heart disease because we didn't understand that it was an inflammatory process. You don't have to have symptoms to have plaque until suddenly something clots and you have a stroke or a heart attack. And so we're trying to get away from people, and women in particular, thinking strictly about risk factors, because it's a horrendous disservice to say, oh, if I treat these, if I act right, and I avoid these risk factors, somehow I'll dodge this and I won't have vascular aging. Now I have to tell you, I've been told by some of my patients that they would rather be told they have a disease than that they're getting older. I don't quite feel that way. I celebrate getting older, and I want to recognize that as I get older, there's some things that are going to happen no matter what, and one of them is vascular aging. So things that speed up or accelerate vascular aging are what we used to call risk factors. Principally diabetes, which is diet related, smoking, to a much, much smaller degree are the cholesterol or lipid profile. But you can have perfectly normal cholesterol, you will still have vascular aging. And blood pressure, which has a much more complex interpretation in women than men because of the change in their arterial nature. And so women have as much to benefit by stopping the aging process with a statin as men do. And again, being on a medication doesn't mean you're unhealthy. It means you have enough foresight to prevent a process and build good future health. So thank you for this little note. If I can, and if I'm invited back, I'll talk a little bit more about the differences in pressure and rhythms and why women have such a hard time having strokes with atrial fibrillation.